Our next speaker is Connie Lehman. Connie is a professor of radiology at Harvard Medical School and the director of breast imaging and co-director of breast evaluation at Massachusetts General Hospital. And I'm really happy to have you here on the stage today.
Thank you. I'm just delighted to be here. So I'm going to talk about artificial intelligence in imaging, and I'm going to talk about it in a specific domain, and that's my area of expertise in breast imaging. But the work that we're doing with artificial intelligence and the images in breast imaging, notably mammograms, but we're also doing work with ultrasound and MRI, will scale across many other areas in radiology and is scaling, not only in radiology, but also any images we can take around healthcare. The exciting work in AI with images of the back of the retina, the exciting work in AI with images of the skin. And some of these are going to shift healthcare more into the home. Others are going to increase the power that the physician has to provide impact in various patient settings. We've had a promise for a long time, a promise to our patients that we will be more targeted in our approaches. We will provide precision medicine, and yet in many areas we have not been able to deliver on that. In my area of breast cancer, we still use very crude methods of diagnosing and separating out different types of breast cancers and treating. We have made incremental gains in finding those patients that can safely avoid radiation or safely avoid chemotherapy, and we need to do better. We think AI has incredible impact and potential for risk-based screening, personalized treatment, and access to all. But we're going to have to work together to move through the hype, to move through the smoke and mirrors, to really have rigorous evaluations of what works and what doesn't work, because we are so much at the early phase of this, and the claims are far overreaching what we're actually proving and demonstrating in clinical implementation. In fact, many say, well, AI is ubiquitous in healthcare, it's everywhere. Most of the studies that are done that really look at how many hospitals have truly integrated what we consider artificial intelligence, not just computerized approaches to healthcare, it's probably right around 5 to 10%. So we're clearly at the very early phase, and that clinical implementation is going to be important. My story really started with an introduction to a fantastic woman at MIT, Regina Barzilay. I met Regina because the man that had recruited me to Harvard, Alphonse Tagian, said, I have a patient that just finished her treatment and I'd really like for you to meet her. I think the two of you are like-minded and you could do great things together. So we had coffee and we talked. Regina had been diagnosed with breast cancer at 42. She was amazed at how little data was available to guide her own personal treatment decisions about the specific type of breast cancer that she had. So she went back, she thought about it, she talked to her lab group and said, what if we took our expertise in artificial intelligence, our expertise in computer science, and moved away from what we have been working on in natural language processing and moved into healthcare, and specifically in breast cancer. And they said, we're all in, and then we started having serious conversations. We certainly felt that it was important that we look at risk-based screening methods. We knew they couldn't advance without accurate risk models. And again, it was that surprise for Regina Barzilay to understand that while we talk about assessing women's risk for breast cancer, the models we have are actually lousy. And we're uncomfortable admitting that, but it is the data and it's true, and we'll go over that. Imaging technology advances have far outpaced our human ability to process information. Human variation and error is a crucial barrier to impact life-saving mammography screening. So there's no performance of mammography. It's in that individual human's workstation on how that mammogram is going to perform, and we haven't embraced that as much. If we repeat the history of CAD and mammo, or computer-aided detection in mammo, we're bound to fail, and so we've learned a lot from that. So these were the 3 sequential mammograms that Regina had as a patient. In 2012, her first mammogram just around age 40, she was told she had very dense breast tissue, but not to worry. There wasn't anything different to do because almost half of women are told that they have dense breast tissue. 2013, the same thing. And in 2014, they said, we see a spot that we'd like to work up. Now, this was her cancer. In some ways, this is a success of mammography. It was very small and identified before it could be felt. But if we look back, and this is true of about a third of the breast cancers we diagnose, in hindsight, we can look back and see something that in hindsight might have been actionable. And this is where we thought better computers looking for change over time might be able to help us in a way that the human eye alone can't identify. And her case is not uncommon. One of the things that we do at Mass General is we review all of our false negatives to really study and learn. Now, some of the false negatives are because a woman had a completely negative mammogram and had an MRI for high risk, and the MRI saw a mammographically occult cancer. Other false negatives are because the cancer grew so rapidly within the year following the mammogram that it just wasn't present, at least visible, at the time on the mammogram, or it was masked or hidden by very dense breast tissue. But there is a subgroup where it's just human error, just overlooking a finding that in hindsight you can see. So this is one example where this little white spot here is just about the size and a fairly similar location to Regina Barzolet's cancer that I just showed. And this little spot and this little spot we can see in hindsight, but as a human was going through hundreds of mammograms searching for cancers, and you have to look at 1,000 patients to find 5 cancers, it was overlooked. Similar situation here. This is overlooked. It's the edge of the film. Could computers do better? This patient returned when it would have gotten larger. So we can learn from this, but even more importantly, we hope we can teach computers to help us be better at our jobs. When we ran, now that we've developed the models that I'm going to share with you today, when we ran Dr. Barzolet's mammograms through the system, this is where the human identified the lesion. This mammogram in 2013 was assessed at the top 2% of risk for cancer. So that would have gotten a very large flag for the radiologist to carefully look at that, or even have a second opinion, and maybe even an MRI, which almost certainly would have identified this. This was in the top 8% of risk. So we are starting to work closely with our clinical radiologists, including myself and my team, on how to integrate and how to use this guidance. We'll talk about some of the challenges and the barriers there as well. Our whole team is very focused on the fact that breast cancer is a global disease and it's spreading around the world. We want to have a domain where AI is not widening the divide between the haves and the have-nots, but it's actually narrowing that gap. And we think that the tools that we're developing are going to be implemented and used worldwide in resource-rich and resource-constrained countries. A lot of my work around the globe has been focused on trying to teach healthcare providers, nurses, technicians, physicians, how to read ultrasounds, how to read mammograms. It's a little bit like trying to boil the ocean. There just aren't enough specialized humans that can be out there to process the amount of data information we need in our imaging. So can smart computers provide access to life-saving screening mammography programs in resource-restrained communities? We think that we definitely can and will. So this is the domain, and I always think it's interesting when you have humans, and especially physicians, that can notice things. It's almost like they get a little hint of something, a little gut instinct about something. We've always noticed that every woman's mammogram is as unique as her thumbprint. If accidentally something got missorted and the current woman mammogram that I'm looking at has someone else's prior, I'm going to notice that. I'm not going to just assume that it's the same because the patterns are so distinct. And these were hidden treasures that we would talk about, but we really didn't know how to collect that data and process it in a way that could help and improve our patient outcomes. So how can we extract this digital data, not just visually, but using our computers? I'm going to run through 3 domains, and we have a lot of different research projects, but 3 are breast density and assessment of that, predicting future risk. Not only is there cancer now in the mammogram, but what about 5 years from now? Could the mammogram tell me what will happen to this woman 5 years or later? And then detection. So density, very timely topic. February 2019, Congress approved a federal legislation that all women be informed of their breast density when they come in for a mammogram. It was a very well-intended bill. It makes good sense that women have their health information shared with them in language that is understandable. The unfortunate thing is it's really misinformation. Being told by a human what your breast density is not a precise piece of data. We did a study of 83 radiologists that had read thousands of mammograms. You can see from this graph, at this end, the radiologist thought 6% of women had dense breast tissue that were being screened with mammography, and at this end, the radiologist thought 85% had dense breast tissue, and everything in between. So when women go in and someone says you have dense breast tissue, you don't have dense breast tissue, it's not a precise assessment. It's a visual inspection. It's very subjective. In states, just an example of how subjective it is, in states that not only have approved this legislation, but also require insurers pay for any supplemental imaging, ultrasound, MRI in women with dense breast tissue, the rates go up even higher. So we don't really think there's a causal factor of insurance plans and women actually developing more dense breast tissue. We think it's driving patients into more supplemental testing because of inherent bias, conscious or unconscious, to assess more women as dense, to put them forward into programs of more supplemental imaging. So we started with that. We had a very large mass of digital mammograms, and we essentially trained the machine to read density. It was a pretty simple task to do. What we really wanted to see was how would it clinically implement at our center. We had very high human agreement. This was at a time, this is a couple years ago, where there was still a lot of fear of AI. Would AI replace radiologists? And so to bring this into the clinic, we had lots of discussions, lots of talks, and then we also gave radiologists feedback when they disagreed with the algorithm. So every mammogram was assessed by the algorithm. The radiologist had absolute easy control to accept or reject that assessment. And then we pulled from all of those where they agreed, and we randomly pulled for where there was disagreement. And this is a confusion matrix that shows that. So this diagonal line will be where there's total agreement. I've covered these up because I want you to guess which it is, but both the machine and man said this is a fatty breast, this is scattered, this is heterogeneously dense, it has more of those white splotches, and this is extremely dense. So that was total agreement. And we'd all look at those and say that's how we would assess them as well. Fatty, scattered, heterogeneously extremely dense. But anything out of this line, you're going to start having disagreement. So either man or machine said this was fatty in this way, and then heterogeneously dense this way. So if you look at these and you were thinking, not as a breast imager, but just visual inspection, you were going to sort these cards, do you think you would collect them more the way the columns are arranged, looking for similarities, these, and these, or would you sort them more like this? So in other words, do you think that these four look more alike, or these four look more alike? So we showed these to our radiologists, and they saw again and again that it's the model that is consistent. It is the human that is inconsistent. Radiologists are surprised when they're shown this. Like all of us would say, we would never, ever call that heterogeneously dense. It's a completely fatty breast. We would not tell that patient she had dense breast tissue, but we do. We do because we're human and because we make errors, and that's just what it is. That process itself, and really thinking about how do you take new technology and ensure it doesn't die that horrible death of never making it into patient and clinical impact, we really focused on the science around clinical implementation, making this easy, making it accessible, making it part of the routine clinical care, and providing feedback to radiologists and getting their engagement at every step of the way. So this is now we do 50,000 screening mammograms a year at Mass General, and they're all processed through this and presented to the radiologist. That is for density, and this month, we hope, believe, we are going to also be integrating in our triage algorithms and our 5-year risk algorithms. And the basic idea for us is just if we have enough images and we have an output we've annotated to say, what happened to this patient with that mammogram, we can use very elegant AI technologies to apply to our mammograms, just in the way that you might have a lot of photos of a cat or a dog, as long as you know that was a cat and that was a dog. And the more data you give, the better their algorithm gets. And we have a lot of data linked to tumor registries with definite known outcomes. We have a very active group of radiologists that are annotating the images, and a fantastic group of colleagues at MIT that we work with. So that was density, and we did the full cycle. We collected the data, we had outcomes, we implemented clinically, and we had everyone really used to it and then asking for more. And our community radiology practitioners who would look over our shoulders when we were working at those sites started to say, we'd like that too. Could we use that as well? And now we're able to compare the AI integration with academic breast imagers that were part of the development to community practitioners that weren't. And interestingly, the uptake and the agreement is not as high with the community radiologists as the academic breast imagers. So we want to get ahead of that, because how often have we seen technology successful in an academic center not translate once we put it into routine community practice? So that's part of the science of our clinical implementation and our thoughts. But if you stop and think about it, we don't really want to assess density. We want to assess that woman's risk of cancer and how good the mammogram is as a test for that woman. Is she at risk of having a delayed diagnosis despite mammography screening? So we moved over into risk prediction. Let's predict in the future, 5, 10 years more, will this woman have breast cancer or not? It is shocking to people who haven't really studied this field to see how poor our risk prediction models are. We put a lot of effort and a lot of time, and have for decades, in asking women questions about how many children they had, when did they start breastfeeding, how many family members have breast cancer. Some of our patients don't have particularly accurate records of their family history, so that can be challenging for them as well. But it doesn't really matter, because at the end of the day, the most elegant, the best models we have out there, the AUCs are 0.62, 0.63. This is not a good way to distinguish women who will develop breast cancer from those who won't. And that is why most academic breast imaging centers actually aren't assessing risk. We haven't at Brigham and Women's, we haven't at Mass General, because it's not a good test. We would be telling women at high risk, they're fine, and women at average risk, they're at high risk. That's what an AUC of 0.63 ends up translating to. So there was a lot of excitement when the models added breast density from the mammogram and saw a little incremental uptake in performance, but it was still quite low. So way back in the 60s and 70s, John Wolfe kept making these human observations. He said there's patterns in the mammogram, and they seem to correlate with women's risk of future cancer. It's not just about the amount of the density, but it's the patterns and the way they're formed. And he wrote this terrific paper in 1967 that says that he noted these elements. The material was coded and later subjected to analysis by computer. 1967. Everyone that I knew when I was going through training said John Wolfe was crazy, he had lots of crazy ideas, and nobody was really using this. And this much later, we're finding out that he knew exactly what we should be doing. We just didn't have the computers to do what we can do now. So we had a large training set and our testing set, and the outcome was yes or no, did they develop breast cancer 5 years out? And what we found was really exciting for us. Our model outperformed all of the existing models, but even more importantly, we identified, and others had noticed this, but I had never realized how dramatic the drop was in performance of the risk models outside of European white women. We all talk about it. Some groups have said they've tried to adjust and make it a little bit better, but the most elegant model out there commercially right now in our African American patient population was worse than chance. It was 0.45. This is what we are using all around the world. I have colleagues that are in Africa using these risk models to triage women who do and don't have a high risk of breast cancer, and it's obviously not going to be an effective method. For whatever reason, and we're not really sure what it is, maybe that's a bit of the black box, our models are immune to race. They perform equally well, whether it is in Caucasian, African American, Hispanic, or Asian groups. I think it's because it's pulling data and information out of each woman's individual pattern of her breast tissue, and we know that those are different across patients. In fact, when our MIT students were waiting for us to give them the cancer outcome data from a very large mammography data set that we provided to them, and they were waiting for the cancer outcomes and they were looking for stuff to do, they were able to predict with the mammogram what the woman's race was, what her age was, and a lot of other factors that they had. So there's a lot of information there that we can predict. Some of those we put into our models, our risk models. So that's an interesting step too for us to start thinking about the black box and the pathways. So then the question comes up, can computers read mammograms better than humans? The first thing is to acknowledge, well, how well do humans read mammograms? There is no one sensitivity, specificity of mammography, and so we're not comparing to this average. We're looking at the range of human performance. I was very fortunate to work with the Breast Cancer Surveillance Consortium. We had a very large database, and that gave us the ability to be pretty nimble when new technology was being deployed to assess the performance of that. So traditional CAD methods in mammography had been around for a long time. It was approved by the FDA in 1998. With reimbursement, the use rapidly increased. There were many different study designs saying, for the most part, this is great, you should use it. People were buying it. Patients were being charged for it. And it was marking different areas on the mammogram to alert the radiologist to potential areas. Well, Josh Fenton said, let's see how this is working in actual clinical practice. And what he reported in the New England Journal was it is not working. In fact, there's no improvement in performance. And if anything, this is the ROC curve with CAD use. It's actually a little bit worse. We're certainly having more false positives. People are getting anxious about all those marks. And so, so you would have thought that people would have stepped back a little bit, asked the question, should we be using this? But instead, everyone focused on the study limitations. The data was from early years of CAD integration. He didn't control for a learning curve. It can take weeks to a year to learn to use CAD. They felt that the data used was outdated. It was technology that used film screen rather than digital. And they said their numbers really weren't that large. So then I decided we would just repeat this study after giving everyone more time to learn how to use CAD. So we only had current performance. It was 2003 to 2009. We only included modern digital mammograms with CAD. We allowed everyone to have a learning curve. We gave them a full year to use CAD before we started collecting their data, and we had almost 570,000 CAD exams, and we saw absolutely no improvement at all with versus without CAD. And more concerning was at sites where radiologists would read with CAD. Some of those radiologists read across the street or across town at centers without CAD. They performed better without CAD. And in particular, it was this, although the error bars are wide, the sensitivity was significantly lower with radiologists reading with and without CAD. They did worse if they were using CAD. So we tend to see, though, that the science doesn't always drive the implementation and the use. So even with very negative large study reporting on CAD, the use continued to increase, and everyone was using CAD for mammography. And so when we looked to see what were the drivers of practice at this time, and this was back in 2012, it was really reimbursement more than the science. I'm not sure we're still in that domain. We have 1 foot in and 1 foot out of it, and we keep waiting to see how that's all going to span. But obviously, from our perspective, we're looking to make sure that not only are we developing the right science, but we're clinically implementing and evaluating to ensure that we're using these tools to their full potential. These are mammograms over the years. In fact, when you read about the early randomized trials of mammography, it's amazing that they found any cancers. This is how the mammograms looked back then, and yet these were the types of mammograms that actually reduced breast cancer mortality by finding cancers earlier when they can be cured. what an improvement we had when we moved into much better film screen and then digital, and of course now we have tomosynthesis, the 3D mammography that's doing thin slices through every breast. So since 2013, all of our mammograms for our patients at Mass General are done with 3D tomosynthesis. It keeps our recall rates very low and our cancer detection rates very high. But with all this modern technology and all this excitement and enthusiasm, which is well warranted for the improvement in technology, there is wide variation across radiologists. This is the JAMA paper that the headlines was, tomosynthesis is great. It reduces your false positives, it increases your cancers. So this graph is showing patients recalled after screening, anywhere from 4% being recalled to 18% being recalled. And this is number of cancers detected per 1,000 screens, from 0 up to 8. So what you want to see, the open circles are digital mammography alone, and the closed is with tomosynthesis. So the average was right here. So they reduced their recall and they increased their cancer detection. That was great as far as an average. But all of these pickup sticks are showing us the wide variation across the 13 centers that were in the study. We had a whole collection of centers that even after tomosynthesis were very high on their recall, and we even had a center here, an entire center, where their recall increased, which means their false positives increased, and their cancer detection went down. So that is the human variation that we have to address. When people say to me, I don't think people are going to trust having a computer read their mammogram, I'm amazed that people trust having humans read their mammograms. I'm like, it's astonishing to me. So, so human variation, we have to acknowledge it. We have to continue to report it. Average sensitivity and specificity of mammography is meaningless when you see how wide. You could go to a radiologist that finds 20% of cancers or one that finds 90% of cancers. Depends on where you go and who's reading that day. I love it that in breast imaging we're required by law to audit ourselves. We have to know our recalls. We have to know our cancer detection. We're not at the point in society where women are told, ask what their performance is. It's knowledge that they have to have. That would be a Pandora's box. I'm sure I'm already winning so many friends doing AI in mammography. I'm sure if I did that, it would just push everyone right over the edge. So we're just going to focus on the computers. This was another study I did, though, with the Breast Cancer Surveillance Consortium, just showing, what wide ranges there are in performance. And when we look at benchmarks, we really have to understand that there is so much human variation in recall and in cancers detected. It's a hard task. If you think about it with tomosynthesis, for one woman, if she's a 5-centimeter compressed breast, that's 50 images for every view. We multiply that by 4 for standard 4 views. It can be more. That's 200 images. Now I'm going to multiply that. I'm pressing my math here, but by 1,000. So I have 200,000 images, and I'm trying to find 5 or 6 cancers. And that is not a good human task. It is tedious. You get tired. You miss things. It is a great computer task, a great task. And how thrilled I will be when, as a breast imager and a radiologist, I can spend more time talking to patients, guiding them through the abnormal findings with the biopsies, with the other imaging, and having those important conversations. As Eric Topol says in his terrific book, this area of AI can bring doctors back to the bedside, back to the patient engagement, back to having that contact and freeing up their time from all the things that they're doing that really a computer could do much better. So as we developed our model, we realized we could provide automated sorting. Right now, our average recall, and we have a very tight window with our Mass General radiologists, is between 6 and 8% recall. So on average, we're recalling 7% of women, and we find 5 to 6 cancers per every 1,000 women that we screen. What if, because of that domain we're in, we could train the computer to show us which 10% should be looked at, or even which 20% should be looked at, and that's what we're working on now. So right out of the box, for sure, we can eliminate 20%, that really don't need a human oversight, but we're rapidly increasing that up. And with the tools in AI, we can also fine-tune the algorithm to exactly how we want to use it in clinical practice. And that's an area that we're very excited about exploring. Do we use it to say these don't need human interpretation at all? Because eventually they won't, but how do we get from where we are now to where we want to be? Do we just provide the radiologist with the risk of malignancy, like, this is a 10, this is a 9, that's an 8. If it's a 10 and I see something, great. If it's a 10 and I see nothing, I can have a colleague look at it. Do I do an MRI? And what about that black box? What if our AI spits out 10 and no one can see anything? Then what's the next step for that, and how is that communicated with our patients? So this is an exciting area, and one that I think we can solve many of the challenges in AI in this domain because we have all the ingredients you want. Great data, known outcomes, engaged patients, and a group of radiologists that are really understanding that this domain, which can be tedious to process, will free them for spending more time on the things that they really love. We're not taking away everything. We're actually taking away the thing that they wish we would take away. So I think that's great. So I'm going to wrap up, and then I'm happy to answer any questions. But acceptance, I certainly hope so. Our patients are hoping for that as well. Globally, our impact will increase incredibly if we're able to embrace this technology to provide better access to higher quality care. Everything is about the data pretty much. We need big quality databases. We must avoid how alluring it can be to sort of take these biased data sets just because it's so hard to get data in healthcare. This is the first data set we developed, which only spanned 3 years. It was over 135,000 exams. We've since updated this to a de-identified database of a full decade. I cannot stress enough, you have to have consecutive women. There are too many databases out there that are very selective, and then they add cancers in, they add benign things in, and those biases are really leading to algorithms that I guarantee will not translate into good clinical practice. So we don't exclude by race or implants or breast size or prior surgeries or high-risk women. It's all women, and we have consecutive exams. I think that's going to be really important. We also can think about, where our domain expertise is. Mine is in breast imaging. Regina Barzilay has total respect for that. Hers is in AI, and she and her team have techniques and methods that I couldn't possibly implement, and it's not my domain. So we're looking at, basic standard architecture such as ResNet 18, moving through the augmentation, initialization, and then the other methods we're using now, modeling risk progression over time, taking advantage of the fact that we have sequential images and looking at changes for that. If we implement risk reduction, and can we see that risk reduction in the mammogram with our AI tools? We've never been able to do that before. I think we'll be able to. And certainly we feel very strongly not only from the mammogram where we're predicting future cancer, but also other diseases. We've already seen that without AI, predicting cardiovascular disease. We're excited to evaluate that as well. I'm not as worried about the black box as some are, because it's sort of like, women will be too nervous, they won't trust a computer, and I'm sort of surprised they trust humans. The black box with AI, so much of medicine is a black box. There's so much that we can't really understand. It's correlational, and then we make decisions based on that. But I do think it'll be important how we act on this. So for example, in this, with our hybrid DL model, this woman is assessed at high risk, and she's clearly not dense. She has a totally fatty breast tissue. So what do I do with that? So this is a high-risk patient. Again, there is nothing on this mammogram at all. Does she need an MRI? Does she need something else? Can I figure it out? We know we're going to have this because our model performs so much better. If we weren't going to have these scenarios where we can't figure out where the signal is, why it's high risk, our model wouldn't be performing better. It'd just be the same as everything else out there. What really drives this is that we have, out of more than 3 billion women, 2 million women are diagnosed every year. That is billions of women that don't need screening at all. We just don't know who they are. we can start to adjust this and really get more into precision medicine and risk-based screening. The 2 million that are diagnosed, we can do much better at detecting those earlier, and we truly believe that we can prevent many of those cancers from happening, and certainly addressing the 600,000 women globally that are dying every year of breast cancer. This is the focus that we have, but what we are discovering and evaluating, we know will scale to other cancers and other diseases, and we're excited about that. I'm incredibly grateful to Regina Barzilay and her team at MIT and my really fantastic group of physician scientists and clinician educators at Mass General that are embracing this technology, participating in it, and really keeping their eye on our shared mission and vision of improving the lives of our patients. So thanks very much, and I'd be happy to take any questions. Yes. Yeah.
Thank you. I don't know where you are in terms of how this technology is shared outside of partners, but for companies who are trying to develop machine learning systems that need very high volumes of image-based data sets, can you talk about how research organizations like yours deal with how to share these data sets with the world, and how companies like ours can actually find very large size image-based data sets?
It's a great question, and I wish I had a really simple answer. What we would like to do is to invite people to explore this journey together on how we can do that. We do think that it's going to take a lot of people working together to do that. There's many different ways to think about this. One is, once we have this de-identified data, how can we make it accessible, and what's the model used for it? There's a little bit that we always have to think about: who actually owns this data? Is it the patients? Is it the hospitals? There are some groups that have tried to have sort of patients providing their own data, so patients can get their mammograms and send them into central places. I worry about the quality with that, and the biases and all of that. Clearly, I don't have a straightforward answer. I can't say, here's the number to call, and that's the process. But I do think having those conversations and exploring, what do good, positive, solid partnerships look like is really exciting. So that area, like access to the data and what kind of partnerships can be formed, I'm very excited about. And then the other is, once we've developed these models, how can others use them? Certainly, we've published 4 of our papers. All of those models are open source. I think that there's a phrase about open source for research purposes, but that's what that is. But so I think that that's there. What I'm really interested in is how are large medical centers and large hospitals actually going to start to integrate this. We've already shown, for example, our density assessment can drive costs dramatically down and be more precise in telling which women are dense and which aren't. So in this federal legislation, it just seems a perfect marriage. Like you want to start doing that. The same thing with centers that really struggle with radiologists who have recall rates of 25%. Calling back 1 in 4 women getting a screening mammogram. So how to implement is also, but it's a full spectrum. How do we start to share this? I mean, I'd be happy to talk further. We have lots of people at Harvard and Mass General working on this and thinking about it. Yes.
So I noticed one is training data set.
Say that again.
The training data set, like a radio slides connected was from a whole other machine.
All of the work that we've done to date has been on hologic machines that I've published. However, we've also evaluated it on GE machines, and this is an area where I think one of our slides where we talk about enforcing generalization across devices. What we're finding is, once you have a model, you can fine-tune to the local environment. So not only do you need to fine-tune from hologic to GE, and you can, but also you need to fine-tune the different software programs and platforms within hologic, for example, because all the machines aren't the same. But we were excited to discover that it doesn't seem like you're starting all over, but you can actually do some fine-tuning, and that'll be important going forward too.
Second part of that question, how does the model work when there are different factors in that? For example, in Neurotech, 2 readers,
Yep. Yep. Yeah. This is the part to me that I get really excited about. So my PhD is in psychology. I'm very fascinated by human behaviors, how people learn, how they change their minds about things and all of that. So the clinical implementation, I think we're going to have to focus on the local culture and environment and what their needs are. And we can actually train the model to perform highest for exactly what application they want to have. So I'm in Europe and I'm saying, well, we double read everything. And then the hospital says, you know, that's really expensive. Radiologists are expensive. What we'd like you to do is have the first read by the computer and then this, or only double read this high group, that's double read and let the rest go. In a center like mine where we don't double read, we're talking about different ways that we're going to implement that. Yes?
So two related questions. One is, the decreasing performance with the CAD is puzzling. Do you think there's a bias that is introduced by using CAD in radiologists by pointing them to different regions?
I think it can be a distractor, and also the CAD companies, at first there were so many false positive marks. You know, you'd open up the CAD and it was ridiculous. It was just, everything was marked. So then they started to say, well, let's start putting a filter on so there aren't so many marks. And then they would say, well, you know, if the lesion's this big, if it's a focal asymmetry and it's that big, they're going to see it, so we don't have to mark it. So when they started doing that to try to reduce the marks, I think there were some radiologists that if it wasn't marked, they didn't want to recall it. And that's the dangerous part, I think. So.
And the second part is it possible to look into the black box to just give a better information? For example, the last case you showed that it looks clear, but it's at high risk. Yeah. What are the features that the AI extracts that maybe also can be learned by a human as well?
Yes, and we're very excited about that as well. That's, again, why I'm so excited to have, you know, these smart partners in AI, because, you know, I wouldn't be able to just pull these out of my toolkit, but there are ways so that you can target, like, what part of the image was being used in making that prediction. You can also do things where you see where, for example, in all these cases, we know where the cancer ended up in the future. So, you know, it predicted this high risk, and we look and see. You can remove that area from the image and say, was it picking up on things around? So we have this seed and soil back in from 1700s, the cancer seed and then the soil all around it. Was it everything around it, her tissue, that was the machine was picking up on, or is it something there at that spot that we just can't visualize? So there are tools and methods that we can start to try to, you know, fill in that black box a little bit. Yep. Yep. Yep, perfect. I'm happy to be at coffee and take any more questions. Thanks.